so we'll move on to our final presentation. We've got David Mack, who's going to speak on management of acute spinal cord injury.
Hi everyone. This is David from National Neuroscience Institute of Singapore. Thanks everyone for attending this talk. I'm talking about the management of acute traumatic spinal cord injury. So my talk really focuses on management of.
Do you want to go to presentation mode for your slides?
Oh, sorry. Okay.
That's great. That's great. Thank you.
Great. Okay. My talk really focuses on only the management of acute traumatic spinal cord injury. So I'm not going to talk about anatomy, injuries to the vertebral columns and ligaments, or other disease affecting the spinal cord, or chronic complications of spinal cord injury. So traumatic spinal cord injury is an epidemic in the modern society with peak incidence in young adults. So most common from road traffic accidents, and they often carry substantial permanent morbidity and mortality. Despite advances in the understanding of the pathogenesis and improvements in the early recognition and treatment, this remains a devastating event and often producing permanent instabilities. Now, spinal cord injury is defined as a damage to the spinal cord caused by an insult resulting in the transient or permanent loss of usual spinal motor, sensory, and autonomic function. We always talk about primary injury, which is irreversible, where the initial damage results from direct cord compression, hemorrhage, and traction forces. So common mechanisms are subluxation of vertebral elements causing cord compression, hyperextension injuries in falls, or retropulsion of bone fragments into spinal canal. On the other hand, secondary injury, which is potentially reversible, it happens within minutes after injury. Secondary damage begins. A hemorrhage, cord edema, and resulting cord ischemia, loss of autoregulation, and hypotension can lead to spinal cord hypoperfusion and the extent of spinal cord injury. Now, this diagram shows the key pathophysiological events that occur after primary injury, which leads to secondary injuries. So basically, vascular disruption, ischemia occurs immediately after primary injury that initiate glial activation, neuroinflammation, and oxidative stress. These acute changes result in cell death, axonal injury, matrix remodeling, and eventually formation of a glial scar. Next, I want to talk about neurogenic and spinal shock in spinal cord injury. So neurogenic shock is an interruption of autonomic pathways leading to hypotension and bradycardia and sometimes hypothermia. It's commonly seen in injuries involving cardiac sympathetics. So it causes a decrease in systemic vascular resistance, decreased inotropism, and an increased unopposed resting vagal tone. On the other hand, spinal shock is the loss of reflexes below the level of spinal cord injury, resulting in clinical signs of flaccid areflexia. Let's not forget, this could be combined with hypotension from a neurogenic shock and a hypotension from hemodynamic shock, for example, in severe polytrauma cases where there is volume depletion. Now, it's important to know about bulbar Calvinist reflex because it is important to determine between complete spinal cord injury and the presence of a spinal shock. This patient has complete spinal cord injury, the recovery is going to be poor. So absence of this reflex is an indicator of spinal shock. So on the other hand, period of the spinal shock usually resolves within 48 hours. And this return of this reflex signals the termination of spinal shock. So you can know the true injury stages of the patients. Now, classification-wise, we use the American Spinal Injury Association impairment scale. It is recommended as the most consistent, reliable, and valid scoring system for these patients, and it is the international standards for classification. So it's grade A to E. I usually remember it's grade A being awful. It's a complete spinal cord injury. There's no motor sensory function preserved. Grade E is excellent. There's normal spinal cord, there's no injury. While B to D means incomplete spinal cord injury, while B means there's only sensory function preserved. For C and D, it's just whether the motor function below the spine level of injury, whether the key muscles below the level has a great muscle grade power of less than 3 or greater than 3. Now, the injury severity is the most consistent predictor of neurological recovery. So the ASIA score is important in the way that it prognosticates how the patient may recover. Let's look at this diagram. It shows that the ASIA A patients on presentation, less than 3% of them are ambulatory at follow-up. while Asia D patients, up to 95% of them are ambulatory at follow-up. Now, mechanisms of spinal cord injury are usually as listed here: flexion injury, hyperextension injury, compression fractures, or flexion rotation injuries. There are we classify the types of spinal cord injury into, as I mentioned before, complete and incomplete. So apart from quantifying them into just paraplegia or tetraplegia, there are incomplete spinal cord injury types also, which is shown here. So there's most commonly described Brown-Séquard syndrome, central cord syndrome, posterior cord syndrome, and anterior cord syndrome, which I want to highlight. Central cord syndrome is most likely the more commonly seen type of incomplete spinal cord injury. It involves, it's caused by a hyperextension type of neck injury, and clinically, patients usually have involvement of upper extremities more than lower extremities, where it affects distal more than proximal muscles, and there's a variable degree of sensory loss. Reason being the alignment of the lateral cortical spinal tract, the upper motor, upper limb, upper extremity fibers are arranged more medially. Now, approximately 3 to 25% of spinal cord injuries can occur soon after trauma. So during either transport or early clinical management. So spinal immobilization is important for all trauma patients with spinal cord injury, especially for those with a mechanism of injury that has the potential to cause spinal cord injury. So effective immobilization includes rigid cervical collar and supportive blocks on a strapped backboard. Sandbags and tape alone is not recommended because there's limited effectiveness in restricting C-spine motion. So as I've mentioned, rigid C-collar and strapped patient on the backboard on the left side, as you can see here. So we manage spinal cord injury patients usually according to the ATLS principles, which is the Advanced Trauma Life Support Guidelines by the American College of Surgeons. So we go by ABC. A is the airway. We always try to first sort out the airway, maintain oxygenation. Let's not forget there's low threshold for intubation for upper cervical spine injuries. You can consider rapid sequence induction and manual cervical inline stabilization with minimal neck flexion. Our breathing, there's the next thing that is important. We always want to closely monitor patient and then at least a high dependency unit, at least for the first 72 hours. And of course, consider early intubation if needed. Circulation needs to be monitored. Let's not forget, in the initial stage of trauma, there may be immediate catecholamine surge resulting in hypertension and tachycardia instead of hypotension. So next comes to D, disability. We usually monitor using the American Spinal Cord Injury Association score, where you classify motor scores and sensory scores in a standardized fashion, so we can compare and contrast how the patient does during monitoring. Now, imaging for traumatic spinal cord injury-wise, there are usually two criteria you can follow. One is the Canadian C-spine rule, and the other one is the nexus criteria. I myself usually follow the nexus criteria because there's a mnemonic you can follow for patients who require imaging to clear. You can follow the mnemonic NSAIDs. So N for neurological deficits, S for spinal tenderness, A for altered mental status, I for intoxication, and D for distracting injury. So in other words, basically a patient who comes into you GCS15 alert with no midline C-spine tenderness, range of movements for the neck is active in all directions without pain, you can actually clear the C-spine. Of course, for current recommendation for symptomatic patients is a high quality CT of the spine wherever available, and we would like to view the axial, coronal, and the sagittal cuts to delineate the exact bony anatomy and relationships. MRI will be useful to look at neuronal structures, and of course, intramedullary signal change on T2 sagittal weighted sequences in the acute period post-trauma may also sometimes provide some prognostic information as such seen on the diagram next to you. This patient may have a poor prognosis because there's indication of a severe spinal cord injury. As you can see, the spinal cord signal is quite widespread. Now, next, I'm going to talk about the potential complication or issues related to traumatic spinal cord injury, and divide it into cardiovascular, respiratory, venous thromboembolism, pulmonary embolism, and other. Other means there could be pain control issues, pressure source issues, GI stress ulceration issues, paralytic ileus, and nutrition issues. Now, adequate blood pressure is critical in maintaining perfusion to this injured spinal cord and to limit secondary injuries, as we've mentioned. Guidelines currently recommend maintaining mean arterial pressure at least 85 to 90 millimeters mercury for the first 7 days after acute spinal cord injury. Let's not forget, patients with traumatic spinal cord injury may also suffer both from neurogenic shock as well as hemodynamic shock related to blood loss and other complications, for example, in polytrauma. So let's not forget to top up the volume with IV fluids, transfusion, or even pharmacologic vasopressors as needed. When, however, in polytrauma patients, they might have indication to go for other surgeries like abdominal surgery. It's important to remind the surgeons or the anesthetists that maintenance of blood pressure intraoperatively is very important to protect the spinal cord. Now, on the other hand, patients with multiple injuries also may receive large amounts of IV fluids. Of course, excess fluids can cause further cord swelling and increase damage of the spinal cord. So remember to monitor fluid administration, strict urine IO, and monitor the electrolyte levels. Now, the most frequently seen pulmonary complications after spinal cord injury are namely respiratory failure, pulmonary edema, pneumonia, pulmonary embolism. Because the incidence of these complications is highest with higher cervical injuries. It could be up to 84% for high cervical traumatic spinal cord injuries. Now, as you can see, the higher the level of injury, it may cause complete paralysis of respiratory muscles and paralysis of the diaphragm. So these patients have a very low threshold of intubation, and a lot of them may have apnea requiring mechanical ventilation. Now, let's not forget, even in a lower spinal cord injury, for example, lower cervical spine or upper thoracic cord injury, weakness of the diaphragm and the chest wall muscles may lead to impaired clearance of the secretions, ineffective cough, atelectasis, and hypoventilation. So these patients may also have respiratory complications as listed. Now, signs of impending respiratory failure includes increased respiratory rates, declining forced vital capacity, a rising PCO2, falling PO2 on the ABG. All these indicate urgent intubation and ventilation, and they also may require positive pressure support. Chest physiotherapy should be instituted as soon as possible. And let's not forget, these patients may also need frequent airway suctioning. Now, DVT is also a common complication after traumatic spinal cord injury because of immobility. It may occur up to more than 50% of untreated patients, with greatest incidence between 72 hours and 14 days. So don't forget to consider calf compressors for all the patients. And we should also consider low molecular weight heparin or even IVC filter within the 72 hours of injury if there is no other contraindications. Now, there's one specific complication that may happen. It's called autonomic dysreflexia. So in response to a noxious stimuli, patients with a high spinal cord injury may produce a sudden increase in blood pressure requiring immediate medical attention. Usually this is a more later complication of traumatic spinal cord injury. It could be a level T6 and above. If this is left untreated or unrecognized, it can lead to seizures, strokes, or intracranial hemorrhage. Treatment is simple. Immediately remove the noxious stimulus, for example, a blocked urinary catheter or impacted stools, for example. Now, I think you need to know the pathophysiology of autonomic dysreflexia as the diagram on the right-hand side. So basically, there's a noxious stimulus related to the spinal cord. There's a massive reflex sympathetic activation, including the splenic vessels, resulting in a high blood pressure. Now, baroreceptors from cranial nerves 9 and 10 detects a sharp rise in BP. It feeds back to the brain, where the descending inhibitory impulses were blocked at the level of injury. So there is a resultant very high blood pressure that's not counteracted. Now, neuroprotection strategies we've mentioned is to limit secondary injury. So as mentioned, we should always avoid hypoxia, hypotension, hypercarbia. Vasopressor support with to at least keep the mean arterial pressure for more than 85 millimeters mercury for 7 days in the first 7 days of spinal cord injury. Also to keep the blood pressure not less than 90. Prophylactic hypothermia is not recommended. How about steroids in traumatic spinal cord injury? There are two trials, the NARCISS-2 and NARCISS-3 in 1990s and 1997. Basically, the conclusion is that there is no class 1 or 2 evidence to support the benefit of high-dose steroids. and its use is not justifiable in view of increased side effects, notably infection and GI bleed. Now, current consensus and guidelines, though, is by Dr. Fehlings in 2017 in AO Spine Journal. It does suggest not to offer a 24-hour infusion of high-dose methylpred who present more than 8 hours with acute spinal cord injury, and also not to offer a 48-hour infusion of high-dose methylpred to adult patients with acute spinal cord injury. But he did suggest, though, a high-dose methylpred can be offered to adult patients with within 8 hours of acute spinal cord injury as a treatment option. So moving on, after the patient has been stabilized, treatment options to consider first includes traction, halo, surgery for stabilization, closed and open reductions, spinal cord decompressions. There are a lot of choices, but it is not in the interest of this talk for the surgical treatments. But I think it is important to know about the timing of surgery in these patients. So from a biological perspective, persistent compression of spinal cord after primary injury is a reversible form of secondary injury, for which when treated early may translate to improved outcomes. So animal studies or laboratory evidence supports the theory of surgical decompression because it attenuates the secondary injury mechanism, and these effects also vary inversely with time elapsed since injury. There is this landmark paper by Dr. Fehlings again in 2012, the STASIS trial. It stated there's clinical evidence to support this hypothesis. Surgery for this traumatic spinal cord injury patients within 24 hours is better and safe. And better is defined as at least 2 grades of AIS grade improvement at 6 months follow-up. Now but then what is early? There are various different definitions for early. A lot of results have shown that interventions within 24 hours will provide the most significant outcomes. But let's not forget, patients with unstable fractures, dislocations, etc. of the spine should be stabilized as soon as possible. These are some of the examples of the papers, for example, by Dr. Marco in 2019-2015. It suggested surgical decompression within the first 24 hours on neurological recovery is time dependent, and within 8 hours could associate it with better outcomes. So from biology and basic science perspective, early surgical decompression does make sense. Although most studies lack the statistical power to qualify as strong evidence, early surgery, if logistically possible, have not shown to cause adverse outcome and may even potentially be beneficial. So in summary, initial neurological assessment and Asia impairment scale grading are important components of acute spinal cord injury management. Now, high quality CT imaging, if available, is the recommended imaging of choice for cervical spinal cord injury patients. Neuroprotection strategies are important to prevent secondary injuries of the spinal cord. And close cardiopulmonary monitoring with maintenance of cord perfusion is recommended to reduce morbidity and mortality in these patients. Thank you very much.
Thank you, David. Another fantastic summary. You three guys, you're real stars. We've reached at one point 100 participants here, so clearly you're drawing the crowds. So we've got a couple of questions, and I'll also introduce Colin Nolan, who is the mentor for this presentation. A question about for patients with spinal cord injury who need intubation, how long do they need to remain intubated? And when do you extubate? Now, this is obviously a difficult decision-making process, but what would you say, David?
I would say initially, if it's a high upper cervical spinal cord injury, of course, the threshold of intubation is low. And during the polytrauma, the patient will have been intubated. But if you talk about when to wean off extubation, I think there are a few factors. First is a neurological assessment, neurological factor of how severe or extensive the spinal cord damage is done, or what the spinal cord injury is. So maybe at some stage, an MRI scan may be useful to tell us the extent of the exact injury, the levels that is involved. On the other hand, when patients are intubated long enough in the ICU setting, the ventilation requirements, the oxygenation, basically the oxygenation ventilation requirements may be complicated by spinal cord injury also. And also they may develop other complications, including pulmonary pneumonia, etc. So all these may come to play as a factor deciding whether the patient is safely be able to be extubated or not eventually. So I would classify as neurological or ventilatory requirements associated.
And some may never be extubated. They may just be converted to a tracheostomy, of course.
Correct, yes, yeah. So some of them may convert to a tracheostomy, which I didn't cover.
If you've got a comment on that?
Yeah, no, I think the decision regarding the duration of intubation is really expectant, and we have a fairly low threshold to convert to tracheostomy in patients that we're worried about.
And then Yutung Lo has asked, how strong is the evidence for vasopressor support for maintaining a MAP above 85 millimeters of mercury for 7 days?
I would say the main thing is really to two components to look at. One is the volume status of the patient. The other thing is, of course, inotropism. So one thing is to drive the mean arterial pressure up. The other thing is, let's not forget, patient may also have a deplete in volume in polytrauma situation. So sometimes not just a vasopressor or inotropes. Transfusion or volume fluid replacement is also important to drive the blood pressure to maintain the cord perfusion.
Do you know of any evidence for that, though? I mean, I'll ask Colm to comment, but I mean, I guess I would extrapolate from the head injury situation where there's actually pretty good evidence from big series that even a single drop in mean arterial pressure below normal can lead to a change in neurological outcome. So I'll probably extrapolate from that. But Colm, any comments?
Yeah, I think there probably isn't strong evidence for continuing the vasopressor support for 7 days. I think the first couple of days are probably more important, first 24, 48 hours, and particularly patients who are having surgery. When we talk about doing early surgery, I think, people say it has been shown to be safe, but obviously it's important perioperatively to maintain the mean arterial pressure of at least 80 to 90 millimeters of mercury.
And then a question from Calvin Lee, which, I think is an extraordinarily vexed question, depending on the setting that you're in, regarding early surgical decompression and stabilization instrumentation for unstable spinal cord injury. May I know how often it's done in your centres? And I mean, I'll preface this with, having visited Africa on many occasions, and pretty much everything will fuse if you immobilize it, even externally, in young patients with spinal cord injuries like this. And so I think a lot of people worry that they've got to have some fancy equipment or very expensive screws to treat spinal cord injury adequately. But I point out that quite often the decompression is the most important thing. And in young people, much will fuse in a good fitting collar or a brace. But of course, that may lead to long periods of immobilization. So instrumentation may be an advantage there. But what happens in Singapore?
Yeah, I think for our centre, we're quite lucky. We've got very easy access to MRI scanning 24 hours a day and quite easy access to the operating theatre. So we try to perform surgery within 8 hours if possible. So we've kind of subscribed to some of the newer papers that show there may be additional benefit to decompressing within 8 hours. So that's what we aim for. But again, it's very dependent on the setting. In Singapore, it's a very small country. So patients are brought to the hospital very quickly and we can treat them very quickly, but it's really depending on the local setting in each country.
Would there be a cut-off time when you wouldn't bother decompressing?
Oh, no. I think we would decompress all the unstable injuries.
Okay, well, it's midnight in Australia. I'm sure the rest of you are having a much more civilized time. But look, I'd like to just say that this has been a really, really great night, or what is it, afternoon for you, evening for you guys. I think fantastic presentations of really good basic knowledge that everyone should have. Thanks to Wan Chu Sao for conceiving these neurosurgical boot camps, president of the Asian Australasian Society of Neurological Surgeons. Thanks to Warralux for being additional panelists there. Thanks to Colum and Jai for being senior mentors of our 3 fantastic young presenters who did a great job. And thank you for attending and asking some questions. And I think we're back same time next week for 3 further presentations. So I'll be looking forward to more than 100 attendees. Who have I forgotten? Oh, and John Bennett, thank you for putting this on Neurosurgical TV. We're all TV stars now. That's fantastic. So good night, everyone.
Good night. Good night.
Good night, everyone. Thanks, Kate.
Bye, everyone.
Good night.
Bye.
Thanks, Kate.
Yeah.
Bye.
Thanks.
Hey, Dr. Warlock, thank you so much. John, thank you so much for having us. And yes, guys, great talk.
Thanks,
John,
Giselle.
you're muted.
Oh, thank you very much. It was
Thanks,
great.
John and Colin. Thanks, everyone.
Thanks, Dr. Colin.
Thanks.
Thanks,
Yeah,
Dr. Chow.
thanks, everybody.
Thanks, Mrs. Young. See you tomorrow at work.
You make